program. Wadud, sir.
Dr. Tushar, I think it's superfluous to introduce Hafiz Bhai because we are so long together in this program. Anybody who is actually here knows about him. But I will ask the audience who is a newcomer, just listen to him and find out how a teacher can be wise, as well as articulate, as well as funny, as well as entertaining. That's how education should be, both entertaining and illuminating. Ladies and gentlemen, this is Professor Chaudhry Hafiz Ahsan presenting you with interesting ECG cases. Hafiz Bhai, the field is yours.
Thank you. That was very nice. So 54-year-old coming with palpitation. So
Sir.
I have actually, yeah.
Sir, can you hear the full screen, because it's coming, full screen is not coming.
Yeah. So I tell my residents and fellows now that to simplify this. So this is a tachycardia, narrow complex, and 54-year-old coming with palpitation, narrow complex tachycardia, but it is irregular, and the heart rate is in 170, 180. Any suggestion? But I think we have less participants, so I'll move on. So this is the differential of narrow complex tachycardia. Can it be AVRT, atrial tachycardia, atrial flutter with a fixed block? But the rate is too high, and if we gave adenosine and it resolved, and we diagnosed this as AV nodal re-entry tachycardia. I will request the faculty to hold your question, because I'm going to show you a few of this. 70-year-old with this rhythm. I usually look at this way, that is it tachycardia or bradycardia? It is regular or irregular, or is there any pattern in the way the relationship of the P and the QRS? So here we are seeing sometimes it is progressing to longer PR and then drop, and sometimes it is 2 to 1 and drop. So what will be the diagnosis?
Sir,
so
as you have
yeah.
already pointed out the P waves, so it seems that there is, to me, it seems to be Mobis type 1 second degree heart block. That means
it is Mobis type 1, and no need of pacemaker. And this is funny. I'm just giving you some what I call the appetizer, and then I'll give you some cases. So these are the appetizers. Why the pacing spike so big?
Yep.
Sometimes we see the pacing spikes big in temporary wear, and then this is the AV pace though, and this is the epicardial pace wear following cabbage. So that's why this is big. Now, sometimes we get challenges with artifacts, how you are going to sort it out. And so the same thing, is it normal rate or abnormal rate, tachycardia or bradycardia? But I would request you that always measure the RR interval and find out a lead where it is little better than the other leads where there are more artifacts. Artifacts can be due to hypothermia, patient motion, the skin contact, could be Parkinson's, and then could be device therapy. Sometimes we see that in devices from the heart failure. Here, you can look at the lead 3, that the P wave can be identified. So this is basically sinus rhythm. Computer got fooled and it read it as atrial fibrillation. The reason I'm showing you, because if we don't confirm atrial fibrillation, we can be misguided, because there are a lot of therapeutic implications and anxiety over this. So, and the best way to sort it out, just get a clean EKG. But if the RR interval is regular, which is the case here, then you also make sure that you're not fooled by the computer reading. Now, what is the diagnosis here? 75-year-old with cough, fever, congestion, and the heart rate, ventricular rate is magic number 148. And then V1, you can see the P wave very distinct. However, lead 2, in the rhythm lead, it looks like a little bit sawtooth appearance. So we called it atrial flutter, but you can give a differential with atrial tach. And I don't know, Rafiq Bhai, are you here? Are you okay with the atrial flutter here? Or
Yeah,
atrial tach?
Yeah, the other one is atrial flutter.
Yeah.
Sir, Rafiq sir, Rafiq sir,
Yes.
একটা ব্যাপারে স্যার একটা there's a question. Though the lead 2-3 AVF there is sort of appearance, but if you look at lead V1, the morphology of the P are quite clear and distinct. So in case of atrial flutter, as we know, it's a macro reentry. So the apparent atrial activity is quite wide. But here the V1, the P's are much more narrower and clean cut. Can it happen?
Yeah, with atrial flutter in lead V1, you can find a discrete P wave. That's not uncommon. But if you look
And
at
then-
lead 2, it's very, very clear that this is flutter.
Right. And then I'm not going into the details, the typical flutter, atypical flutter, the clockwise, anti-clockwise. Sometimes it can be confusing, but I give you a very general cardiology 2 cents, that typical flutter using the ITMAS and the right-sided, but everything else is left-sided, atypical. And then clockwise, anti-clockwise is how the macro reentry get the depolarization. So this is interesting EKG for many reasons. 43-year-old, okay, so 43-year-old coming with this, and the ER emergency room was concerned about STEMI. So what is your comment?
Again, sir, if you follow your dictum or follow the dictum of ECG, the rate is at around that 150 range.
Okay.
And the ST segment that is presumed to be elevated is not the typical ST elevation that we see in MI.
Okay.
So again, I go for
So a couple of things, right? The tachycardia and regular tachycardia, but if you look at the early depolarization, it is very narrow. So this is not falls into like wide complex tachycardia, is narrow complex. And if you look at lead 1, is I think you can say that there is P wave and it's probably sinus tachycardia. The bigger challenge, and that can be explained by the patient's clinical context, that fever and immunocompromised host. But the bigger problem is that there is also this ST elevation, that is shoulder down ST elevation, and sick patients in COVID time, we have seen this time and again, that the acidosis, hyperkalemia, hypoxia, pushing the ST segment and giving this mimic of ST elevation. So this is not the typical, what we call the type 1 ST elevation MI. And people get worried and also can be fooled and then unnecessarily telling the family. And I also told the ER that you need to address the futility of care because of the metastatic breast cancer. Patient is pretty sick, hypoxic, and then respiratory issues. So we did not do anything. What about hyperkalemia? We suspected potassium was 5.5 and the acidosis. She died later on. So we did not do anything for this patient. So now the cases. 57-year-old, history of reflux, presented with substernal chest pain. And this EKG. This is, I was waiting. So, you know, in the restaurant in the US, sometimes they call you that catch of the day. So that means the fish that is they got on the day, they cook for you, like the Hilsa restaurant in Bangladesh near the Padma Bridge. So Padma Bridge er kache ekta iye ache na, oikhane fresh খাবার দেয়। তা আমি ওটা ওয়েট করতেছিলাম যে আজকে কি হঠাৎ করে উইকেন্ডে পরপর কেসগুলো ওইগুলোই আমি দিচ্ছি। এটা আমাদের উইকেন্ডের কেস, ফ্রাইডে নাইট। এটা হলো যে চেস্ট পেইন। What to do?
I'll do a posterior EKG.
So inferior leads does not have any ST elevation. So will you call it a STEMI and take it to the cath lab, or you'll call it non-STEMI and then do this cath on Monday?
I'll be going for posterior lead.
And actually, patient has having active chest pain, V1 through V3, the ST depression is C and slight upright T. That's highly suspicious for posterior STEMI.
So this is Aziz Bhai, this is what you got. So we put the leads V7, V8, V9.
Yes.
He is there. He's posterior, Mike.
So, okay.
But I also suspect there is RV infection.
Okay. Inferior is isolated posterior is rare, probably 3 to 4% isolated posterior. But the posterior with inferior is not uncommon. Could be anywhere between 20 to 30%. And yes, it can be RV, and hypotension can be a big problem. So I should not ask this because Rafiq Bhai will not like that we talk about angio, but this is a common problem that don't be fooled by this, because that was a CONAS branch, but the RCA. So culprit,
Mid RCA.
but sometimes we get this algorithm for the EKG that RCA versus CERT. But if it is isolated posterior, then what is the culprit? So I'm going back, showing you this. And then now what is the culprit? So late in the injection for the CERT, there is a dye seeking in the CERT, and I knew that it is a posterior, isolated posterior, statistically speaking, more likely to go for the CERT, and we actually went for the CERT and then we opened the circ, and then RCA is totally Renthrop grade 3, full collateralized. So we did not go after this, and then we'll bring back and assess the LAD, and then think about LAD RCA cabbage versus just LAD PCI, and take the collateral to the RCA, or the LAD, and then a third setting, we'll think about CTO of the RCA if there is significant ischemia in that territory. But for now, patient is doing okay with the intervention of the circ. So 2-3 AVF ST elevation, and then the ST depression in the precordial leads. But when there is circumflex involved, then we usually observe lead 1 AVL depression, and V5, V6 usually not showing ST elevation. But when there is the V5, V6 ST elevations and lead 1 and AVL, most likely RCA, and particularly if the ST elevation is noticeable in the, this is the algorithm. So ST elevation is more in lead 3, and lead 1 and AVL, if it is yes, then it is most likely RCA. Now, in this report, they said sensitivity and specificity. Look at the specificity, 71%. There is actually a Chinese study that looked with the criteria, the specificity fell further. So almost like toss up that what is the culprit. So EKG helps you for the culprit, but it is not a really a Bible type rule book. I care more about the clinical condition of the patient. Is the patient hypotensive? And is there a big RV infarct? Because prognostically, RV infarct will make a difference, because patient hypotension, RV infarct, patient may not long-term do that well compared to just without RV infarct. Okay, so
Hafiz bhai,
yeah.
may I have a question here?
Yeah.
Because these are the you already have the specificity and the sensitivity of the ECG for television, especially for LCX and RCA, that is there. But at the same time, it is true that when you will have a CTO RCA with Renthrop grade 3 or grade 2 collaterals are there, and when you are seeing that acute occlusion of the LCX, so not all the time the ECGs will tell the same story here, because sometimes you see even the LAD is getting occluded, but you are seeing that the ST elevation in the 2-3 AVF or subtotal occlusion or a little bit TIMI2 flow in the LAD, but as there was CTO RCA, or it's behaving like the inferior MI sometimes. So it's a mixture of the things, and that's why the ECG is not that much sensitive for that one. And because the collaterals, I think, is a factor here, because these collaterals are not getting enough flow, which they were getting before, and that's why it's a mixed up thing, isn't it? Yeah. So maybe the RCA and also the LCX both can be involved here.
We actually, that is actually Wadud's favorite thing, that if it is a wraparound LAD versus CTO of the RCA, sometimes you see the EKG changes. And if you look at the study, EKG studies, the sensitivity goes higher, but the specificity may fall, you know. But good thing is that, and this is I tell the fellows, you need to know the EKG, and in the context of the EKG and clinical presentation, when there is a multi-vessel involvement, you need to figure out which one is the culprit. Because, for example, if I went after that RCA without giving much thought, I probably would be spending, you know, CTO hours and not much help. But I went after the circ. It was difficult, but I used the, you know, the over-the-wire balloon and that. But it was okay. Patient is doing great, actually. I just rounded early, and patient is doing fine. So this is another example.
Another just a tricky question is here. A very small question is here. You have told that if it were not a stimulation or is a suspicious thing, that whether you are not understanding whether it's a stimulation or not, or maybe the first ECG when you have shown without the posterior, the right one, and then it's a non-HTMI, and you will wait till Monday. But if it is a high-risk patient with non-HTMI, then why it is till Monday? That is also a class 1 recommendation to go for the initial one. That's it. That's out of ECG. I'm asking that one also.
Okay, so by the way, that was a joke. That Monday,
Okay.
because that usually people do. They usually try. This is a good point that you got on that comment, but that was a joke, Saidul, because ongoing chest pain and ST depression, there is no such thing called cool off, chill out. It does not work that way. And Deepak Bhatt did this crusade, and then we have the National Registry for Myocardial Infarction, that the longer you wait, it is actually bad. So if you go within 48 hours, then it is better than waiting for too long. Now, thankfully, Deepak Bhatt did not do an analysis for within 6 hours. Then we would be all the time in the hospital. But because earlier is better, that's the whole theme. And at the same token, if you look at the hot non-STEMI, or what we call the Braunwald's classification, where he says that if the patient having ongoing pain, dynamic EKG changes, rising troponin, non-sustained VT, decompensated heart failure, cardiogenic shock, those patients you don't wait. Absolutely. Good point. I actually was making fun that don't wait for Monday. I meant, yeah. Hello.
এটা হচ্ছে সাইদুর ভাই যে কোশ্চেনটা রেজ করেছে আসলে ফার্স্ট অফ অল ইট ইজ ACS ফার্স্ট ইমপ্রেশন ইট ইজ অ্যাকুট কোরোনারি সিনড্রোম আপনি যদি কনফার্ম না হন যে ইট ইজ ট্রু পোস্টেরিয়র অ্যামাই দেন নেক্সট থট উইল কাম ফরওয়ার্ড ইট মাইট বি কেস অফ non-HTMI দ্যাটস ওয়াই হি রেজ দ্য কোশ্চেন আপনি কেন সোমবার পর্যন্ত অপেক্ষা করবেন আসলে তা না আসলে হচ্ছে ইট ইজ অ্যাকুট কোরোনারি সিনড্রোম মোস্ট লাইকলি ট্রু পোস্টেরিয়র অ্যামাই কিন্তু যদি সেকেন্ড থট না থাকে ইউ শুড গো ফর রিপিট ইসিজি এন্ড পোস্টেরিয়র এক্সটেনশন আছে কিনা দেখবো তারপরে যদি না হয় বাই দিস টাইম ট্রপোদিন রেজাল্ট চলে আসবে দেন আই ক্যান মেক ইট যে আমি আসলে আমি কোন দিকে আগাবো অবভিয়াসলি প্রাইমারি পিসিআই অবজারভেশনে আমাকে থাকতে হবে আর না হলে আর্লি ইনভেসিভ স্টাডিতে যাইতে হবে এটাই হচ্ছে আমার মনে হয় অ্যাপ্রোচটা হওয়া উচিত ছিল
and if you leave it for next day, also not good, because you fail to recognize the true posterior ST elevation MI.
আর এখানে এটা হচ্ছে ট্রু পোস্টেরিয়র আমি আই এম শিওর প্রথম থেকে ছিলাম যেটা বলছিলাম এখানে কালপ্রিটটা হচ্ছে LCX এখানে কোনো ডাউট নাই অনেক সময় কনফিউশনাল স্টেট যে RC এবং LCX both are occluded but which one is the most likely culprit if you look at the EKG it is truly gives you a clue for true posterior MI most likely than understood otherwise second thing if you look at there is no ventricular flow in LCX but there is some ventricular flow in RCA so it gives another clue that LCX is the culprit vessel so finally if you open it up then it gives you a clue if hemodynamics improve that definitely it is proven that it is the culprit vessels
yeah that is the final thing like myocardial viability you do the cabbage and the LV gets better then you know that you are right how about LV not getting better then you say oops I did a misfire so
right.
Pain resolution may not happen then you may need to go back if you did not get the culprit right but here is some clues is that R wave is tall in V1 and then suddenly V1 TU is upright and ST depression these are clue that there may be a posterior and if you then do what Wadud was suggesting that posterior leads V7 V8 V9 then your pickup rate will be high and usually it is not a problem if you see the inferior is elevated then you know that infra posterior association is not that uncommon. But if it is isolated posterior, then it may be a problem. Somebody is saying, can it be myopericarditis? The question is, it can be in the differential, but for myopericarditis, we don't have any other clue that PR depression, AVR, ST elevation, and in myopericarditis, usually it is not that localized in V7, 8, 9. Localized pericarditis is pretty uncommon unless like trauma or post-CABG. Usually it is global.
And I'd like to make a small comment on that from my clinical experience, that whenever you see slight ST abnormality, V1 to V3 leads, or up to, it could be up to V4, and there's a clinical scenario there, please do be suspicious for posterior MI at least, and try to do right, a posterior ECG, because otherwise this is the most common MI that we miss. In clinical scenarios, suggesting even minor ST abnormality, maybe not classic that we see, depression, do repeat EKG, like in 15 minutes, 30 minutes, is ongoing chest pain. Highly be suspicious for posterior MI.
Thank you, Aziz Bhai. Happy to clarify a question answer, Aziz Bhai. And I don't want to say another thing. STEMI has two parts, ST elevation and MI part. And I have said this so many times, and I will continue to hammer it. The MI part is clinical. If the MI part, the clinical part is overwhelming, don't look at the EKG too much. On the other hand, if the EKG part is overwhelming, then look at the clinical part as that this, patient says it is epigastric belly pain. No, if the EKG is slam dunk inferior ST elevation, sometimes they may have nausea, vomiting, and some epigastric discomfort. It is RCA. So the overwhelming evidence of EKG, good. Overwhelming symptoms, think about it. The rest is need to correlate. And that's why this whole session, the EKG basics and beyond, that's the beyond part. Now, this is a complex issue, but it is from yesterday. And I thank my fellow Dr. Chris Susu to put it together last night for me. So now, Rafiq Bhai, you know how I get the cases. So this was my case yesterday. So out of hospital, B fever arrest, right? One shock, the return of circulation, but mentation obtunded and little bit of respiratory problem. This is the EKG after the shock. Comment?
ST elevationটা কিন্তু widespread.
ST elevation in the precordial leads and also in lead 1 maybe, right? But what is worrisome is that probably sinus tachycardia. And sinus tachycardia is a bad thing following this. So patient is intubated and what to do next? Mentation obtunded, downtime, the CPR time more than 10 minutes. So what to do?
You have a class 1 recommendation for this patient to go for the cath, no doubt about it.
Okay, so what in the class 1 recommendation, what in the assessment that would be less compelling to go to the cath lab, less compelling, like you assess the more the cardiogenic shock, the patient age more than 75, pH 6.9 or 7.1, high lactate, patient has malignancy and metastatic diseases.
Hafiz bhai, you are putting down the other things later. Then why you are asking this?
No. But what I'm saying, first of all, when there is an intubation and out of hospital cardiac arrest, the door to balloon time is not demanded. The patient also had a fall and has a suboccipital area swollen, localized hematoma, and maybe one fracture. So that is the scenario. And then mentation obtunded, that is not prohibited, because actually Ehsan Bhai from Delaware, he published that in the STEMI situation, regardless of the mentation, you should go. For the non-ST elevation, maybe you can buy time. And now recent publication with the non-STEMI, they said that you probably be better off evaluate further. Cardiogenic shock is a problem, particularly in the elderly, but that is a different thing. This patient did not have shock and blood gas was not bad, CPR 10 minutes, and patient has history of previous coronary intervention, stents in the past, and that's all we know from the wife. So what we did the story doesn't end here. We did a quick CT on the way to the cath lab, and CT was negative for intracranial bleed. I worry about interparenchymal bleed or subarachnoid hemorrhage, etc. Not like a little external hematoma, because we give blood thinner, and if there is an issue, we can tackle that. So this is what we found in the anticipating problem. I went from the groin, and then you can see that a vessel is missing, which is the LAD and the RCA. And it looks like there is RCA stent. RCA stent is patent. So now, and this brings back the question of EKG and how much importance you give to the EKG. We did a delayed panning. Okay. So this is the echo. LV gram. I'm going to show you the echo. Will you do? There is always this question about, does LV gram helps? By and large, if there is a good ultrasound, I am okay, but I try to assess the EDP, particularly sick patients. That gives you a lot of information. And I have a very low threshold for doing a quick right heart. And if it is a shock, then mandatory right heart. But I'm telling you,
but that's at the expense of 30 or 20 or 30 cc volume overload.
Yeah. Kidney came out okay. So this was the contrast echo, right? Now you can see that whole apex is out, rather dyskinetic as it is. So I did a quick EKG in the cath lab. So you saw the EKG before, and now LV is almost like a dyskinetic aneurysmal. And then you remember the EKG on presentation, and now the EKG after the ventriculogram. So what to do now? And then I have a question for Rafiq Bhai. The case is not done yet. So I was wondering that what is the substrate for the VFib? We don't know much. Was he having pain? Was it like and then that led to this or what? But it is very difficult for me to just say that this is LV aneurysm and he went into sustained VT-VF and had a sudden cardiac death. But that is a provocative thinking. But the ST elevation was real, and if you go back, I looked at this carefully. I went back, and that I also would request, particularly those who are doing angiogram not that long, there is no harm to go back and look at the angiogram again and again. If you look at this view, you see that there is some suggestion for that the LAD territory, there is a there is a dye seeking in the LAD. So I am convinced that this is the LAD is the culprit. So I did actually open the LAD. And I did the IVAS and etc. And then optimized stent inflation, which is probably one of the reasons.
He has a previous stenting in LED, isn't it?
Yeah. So that's why I did the IVAS and then dilated more. And then my question now is that good enough? I don't know, Rafiq Bhai is here because it is a primary VF. You take care of the LAD and then you call it a day, optimal medical therapy. He's still intubated. His mentation is getting better. We are working on his vent setting, and we may be able to extubate, if not today, tomorrow. Although he has a little bit of fever now.
I have one
Aziz Bhai?
question I have that, when you see the second EKG that you did in the cath lab is queued out everywhere, right? In order to form like total Q wave, it takes time. So what's the time frame when you had cardiac arrest? It was pretty quick that you did the hard cath in between.
Probably
we don't
45 minutes.
Yeah, the main concern right now, the Q waves that, so the Q wave, so there's old, I think before the event happened, where the patient has already aneurysm there, because it's already Q wave already formed there, so it has to be like 36 hours, around like 48 to 36 hours that we see normally total Q wave form and persistent ST elevation.
So the Q wave, the Q wave part, let me.
Yeah, I can do the first one.
So look at the first one, right? Do you think there is Q wave in the first one?
V1 to V3.
Yeah, there is Q wave. So it is not a new Q.
ST elevation is disproportionate. It looks like acute.
Yes, that is correct.
Aneurysm do not have that type of elevation.
And one of the reasons that normally if the ST segment get better, then you think, oh, is there any reperfusion happen? But I have the angiogram, I have the ventriculogram, and I have the repeat EKG. Actually, the ST segment got better, actually made me worried that this is not LV aneurysm. Because if it is LV aneurysm, it will be persistent. With the
but Hafiz Bhai, the first EKG was in a tachycardic state. And the second one is in a normal sinus state and in a normal. So in a tachycardic stage, in these sort of patients where a previous MI is there, and within 45 minutes he has come, and by these 45 minutes patient has an cardiac arrest only for the occlusion of the LED. Maybe the arrhythmogenic scars there. In the LED territory, it may happen also. It may be one of the causes there.
Okay, so I don't know everybody followed what you said, but I'm just re-emphasizing what you're saying. Post cardiac arrest or in an acute cardiac event, the tachycardia and the double product like the heart rate and afterload high can give you dyskinetic segment worse and make the ST segment worse looking. When all these settle, that may got better. But what is important here, that the better means that it is not LV aneurysm alone that can explain this. So I thought that there may be some reason that I should go after. And the dye seeking, the acuteness, all these, it is difficult for me not to open the artery. And
how much time you needed to open the artery? How much time? Was it difficult to open the artery?
Yeah, I had to go over the wire balloon and cross a couple of wires, but we got it reasonably good. Our average time, because we maintained the record. So
no, I'm telling that whether it is softish plaques were there or it was really. something like
No,
after the occluded segment.
After the occluded segment,
LAD?
I had to cross. Yeah. So that's probably the reason why it closed. But overall, maybe 35, 40 minutes. But the next case, which I'm not showing, was an RCA that took me about 2 hours for 4 stents. But anyway, my question to Rafiq Bhai, I don't know Rafiq Bhai is here. Is it okay to call it a day and not put an ICD? Or you still think that we should put an ICD? If the patient wakes up and there is a meaningful recovery, then before going home, will you be okay?
Should you not wait for some time, 40 days, before you decide?
That is otherwise cases. But this case already had a previous MI, previous, yeah, exactly.
The question
So,
right now, that's fundamental question comes here, the same question, that if you think that VFib arrest happened with acute event, acute occlusive event, then you have to wait. If you think that the VFib happened from the scar, then you need to put it. That's the fundamental question we need to answer here.
That's why I have asked this question.
Yes.
So I have raised this question.
So I gave you all the data. What is your answer?
Very difficult.
So
Hafiz bhai, there is a gray zone here. There is a gray zone here. So we have to wait and see.
I think we can wait.
At least we can, if you have a high suspicion, at least you can do the vest for now and see and how he does. That would be my answer.
So I'm thinking about that at least we give a live vest. This is a wearable jacket for sustained VTVF as a protection, but and we are calling it VF with the MI. Then I think there is justification. But for secondary VF, secondary prevention, the live vest is not the recommendation. Then ICD is the recommendation. But I'm going to show the next case and then maybe we'll call it a day. This is everybody agrees that this is tachycardia, white complex tachycardia.
Yeah.
And question is it VT or is it SVT with aberration or paste or the differential of white complex tachycardia? So this patient had sustained, then shocked, and this is the story. 22-year-old and has myotonic dystrophy, and then gave amio. QT was a little bit prolonged, but after this, patient went into a VT storm, refractory VT, shocked, amio. Then we became a headless chicken, lidocaine. And this is the echo on the 22-year-old. So RV is not dilated, LV clearly is significantly decreased. So what is the plan? So there is a good review if anybody wants to. Arbustini is the cardiomyopathy guru. You know, he describes this morphological classification of cardiomyopathy: dilated, hypertrophic, restrictive, and then others. And that also includes myotonic dystrophy, usually gives dilated cardiomyopathy. And there is a variety of clinical manifestations, and the prognosis can be bad. And in the EP world, this is the way they think that the triggers, the mediators, and how the substrate is going on, and how you can address this and maybe have some impact in some cases in the remodeling of the ventricle and get the ventricle better. But for the sake of time, I want to tell you that what we did in our patient. Let me show you the EKG. And where is that? Okay,
Previous
so
one.
any idea that what kind of VT it is? So like any refractory VT, you know, in the adult world, we worry about scar, aneurysm. Pseudoaneurysm is also vulnerable, but it can be a sustained refractory VT, and it may not work with the antiarrhythmic shock. And then if the patient has ICD, it can really drain the generator with the repeated shock from the ICD. So it is important to address the VT and then go after the VT substrate and look for scope for VT ablation. So looks like Rafiq Bhai has left, but we thought this is right bundle left axis. Looks like fascicular VT. It is one type of fascicular VT. And then we put impella because the patient had also heart failure, and then give the LV support. And they took about 3.5 hours to ablate the VT. And patient is doing okay. Now we are thinking about putting an ICD because in case, but the patient is having some fever, pneumonia, extubated, and then we'll see whether we can put an ICD and then think about further evaluation for the cardiomyopathy. So I will stop there if any questions.
Sir, was there before the EP study or radiofrequency ablation, did you try for a sympathetic denervation, which was which might be easier in that case?
Which one?
Sympathetic denervation.
Oh, sympathetic denervation is not easy because it is a cervical ganglia. They, Dr. Shiv Kumar from UCLA, and I have worked with him, and I have sent a couple of my patients, and they have done it, and he has published as well. But it is not that easy, and he will probably tell you that same thing, that they will go after if they have issue. If the initial ablation fail, you will not go to cervical denervation, sympathetic denervation first.
And
But good point.
Yeah, but fascicular VT probably would be relatively not that difficult to ablate because if you can find this circuitry in that
Yes.
area, it would be not that difficult, right?
In case of fascicular VT, that ablation is in fact not quite hard. But considering the substrate and the myotic dystrophy, it is unusual to be fascicular VT. Moreover, that the morphology of the ECG doesn't fit the typical picture of fascicular VT in this case. Maybe
Yeah,
the,
so if
focus
anybody
is
interested,
close around the
give a
fascicular
search.
region.
Yeah, I
That's
think
why
you're
the
right.
ECG
That in a way that the substrate and LV dysfunction is still there. So is ablation foolproof? It is not like RVOT, tachycardia, and VT, and then you ablate. You don't put an ICD here. You are not totally immune. So we'll have to protect, and therefore giving ICD. Anybody interested, I would request to read the fascicular VT and circulation, and give a search. You will get this paper, really nice. They describe about 3 types of fascicular VT, the natural history and prognosis, and different therapeutic modalities. All right. Thank you all.
Wadud sir, I'd like to request Professor Abdullah Chaudhary sir.
Now, Jamil Bhai, will you make some comment? Jamil Bhai is here.
Yes, sir.
Jamil Bhai?
Yes,
Okay.
thank you very much. Actually, always I learn new things from Hafiz Bhai's lecture. Always his varieties of issues are excellent. all are teaching form of ECG. Very interesting. Thank you, Hafiz bhai. Thank you.
Thank you. It is always a privilege.
এরিথমিয়া এবং যে অ্যাকিউট কেসে যে কেস বেসিক বলে বোঝা যায় যে দেয়ার আর কেসে যেখানে রেগুলার কোনো ডিসিশন দেওয়া খুব কঠিন ব্যাপার।
Sir, sir, there are two. They want to ask some question to sir. Dr. Aminul Kadir Mirza and Dr. Ikhtiar.
Sir, Assalamualaikum sir. স্যার আমাকে শুনতে পাচ্ছেন?
হ্যাঁ হ্যাঁ
হ্যাঁ শিওর।
আমি ডাক্তার মোহাম্মদ আমিনুল কাদের মির্জা, ঢাকা থেকে বলছি। আমি আনোয়ার খান মডার্ন অ্যানেস্থেসিয়ার প্রফেসর অ্যান্ড হেড। আমি আজকেই প্রথম জয়েন করলাম স্যার। আমি আজকের প্রেজেন্টার যিনি চৌধুরী আহসান স্যারকে অনেক অভিনন্দন জানাচ্ছি এই প্রেজেন্টেশনের জন্য। অ্যাকচুয়ালি এটি খুবই স্পেশালাইজ ফর মি, যদিও আমরা অ্যানেস্থেসিওলজিস্ট হিসেবে কার্ডিওলজিস্টের সাথে খুবই ওতপ্রোতভাবে জড়িত। অনেক সময় আপনাদের অনেক সহযোগিতা আমাদের লাগে এবং সেই সহযোগিতা নিয়েই আমরা ওটিতে এবার ইলেকটিভ অপারেশন হোক অথবা ইমার্জেন্সি অপারেশন হোক আমরা ম্যানেজ করি। আমার একটা প্রশ্ন ছিল শুধু যে আজকে যতগুলো কেস প্রেজেন্টেশন আপনি করেছেন, আমি চৌধুরী আহসান স্যারকে জিজ্ঞেস করছি, এর মধ্যে অধিকাংশই মেল, একজন শুধু ফিমেল 43 বছর বয়স্ক। তো আসলে ইনসিডেন্সটা কি আসলে এরকমই ওখানে? আমি আপনার ইউএস এর হিসেবে বলছি, নাকি আসলে এটা আপনি র্যান্ডমলি সিলেক্ট করে আজকে প্রেজেন্টেশনটা করেছেন স্যার?
ও জেন্ডার?
জি স্যার,
এটা
একদম শুধু ফিমেল, বাকিরা সবাই মেল।
আচ্ছা, না আমি জেন্ডার হিসেবে সিলেক্ট করি নাই। আমাদের ফ্রাইডেতে স্যাটারডেতে যে দুই কেসগুলো আসছে এইটাই, শুধু যে মায়োট্রনিক ডিস্ট্রফি ওটা আমাদের লাস্ট মানে ইয়ার কেস, গত সপ্তাহের কেস। আর এটা আমি এই উইকেন্ডের কেস। আমি অ্যাকচুয়ালি আসলে আমাদের ফেলো এগুলো কম্পাইল করছি। আমি বলে দিছি যে এটা কোনো সিলেকশন বায়াস না। আর আমাদের কেস ওরকম আসে না যে শুধু ছেলেরাই আসতেছে, মানে মেয়েদেরও আছে।
থ্যাংক ইউ স্যার, থ্যাংক ইউ স্যার, অনেক ধন্যবাদ স্যার।
স্যার আই গেস স্যারের
আমি একটা কথা বলি যে যে পেশেন্ট নিয়ে এখন ভুগতেছি আমরা, BMI 50, পিকুইকান, বডি ওয়েট 525 পাউন্ডস, সিভিয়ার এওর্টিক স্টেনোসিস। আমাদের ক্যাথ ল্যাবে তাকে নেওয়া যাবে না ওজনের জন্য, ওআর টেবিল তাকে ধরবে না, CO2 হাই, সে ফিমেল, কিন্তু তাকে নিয়ে আমরা বিপদে আছি।
525 পাউন্ড?
হ্যাঁ।
সবাইকে তাহলে ধন্যবাদ। থ্যাংক ইউ।
জি অনেক ধন্যবাদ, অনেক ধন্যবাদ।
থ্যাংক ইউ।
থ্যাংক ইউ।
ওয়াদুদ স্যার, চৌধুরী হাফিজ হাসান স্যার বলছিলেন আফটার 10:30 বাংলাদেশি টাইম he has to do some work in his hospital, so he has to leave.
Okay.
Wadu sir, I request you to sum up the presentation as the normal presentation of
already বলেছেন। হ্যাঁ, যে
very crisp presentation.
নেক্সট কি এটা তুমি ঘোষণা দিয়ে দাও, নেক্সট কি থাকবে?
স্যার আমাদের নেক্সট প্রেজেন্টেশন হচ্ছে 27th of this month, and the topic is normal ECG in children. আমরা এর আগে করেছিলাম normal ECG in adult, এবার আমাদের টপিক থাকবে normal ECG in children, and our presenter will be Dr. Naharuma Haidar Chaudhary from National Heart Foundation.
Good. Looking forward to that.
And also, sir, we have to there a big program coming on 17th of this month. আমরা এটা
তুমি কোথায় কি এটা বলে দাও, মিলন অডিটোরিয়ামে সবাইকে জানিয়ে দাও।
আমরা আগামী 17ই নভেম্বর ঢাকা মেডিকেল কলেজের শহীদ ডক্টর মিলন অডিটোরিয়ামে ECG ফিয়েস্তা 2022 আয়োজন করতে যাচ্ছি। And we hope that this will be a very big event. It will start from 2 p.m. and up to 8 p.m. it will be there. And hope the participants will enjoy the program. Wadud sir.
Inshallah.
So I request Wadud sir to close the session and then we leave.
Yeah, just close it.
Okay, sir. Okay, sir.
All right. Thank you very much, everybody.
Thank you all.